Thank you for the introduction, and I'd like to thank the conference organizers for this opportunity to discuss with you the Merck HIV pipeline. As you can see outlined on this slide, Islatravir, which is a novel non-nucleoside reverse transcriptase translocation inhibitor, is really the foundation for our HIV treatment and prevention development programs. And outlined on the slide are the programs for both treatment and prevention that I'm going to be discussing with you over the next several moments. So on this slide, you can see the chemical structure of Islatravir, and in color are the moieties on the structure that are responsible for its inhibitory properties. 4' ethynyl group responsible for inhibition of translocation, and the combination of the 4' ethynyl and 3' hydroxyl group responsible for delayed chain termination. And it is a combination of all of these inhibitory properties which result in multiple mechanisms, and they contribute to the high potency of Islatravir against HIV-1 and drug-resistant variants and its high barrier to resistance. What I've outlined for you on this slide are what we believe are those attributes of Islatravir that uniquely positions it to be the foundation of treatment and prevention regimens. So its high potency, its unique resistance profile. It has been safe and very tolerable in clinical studies to date. It has a long half-life, and it does have a favorable tissue distribution. So the first program that I want to talk to you is the one circled here, the once daily Islatravir doravirine program. This is the design for the phase 2 ongoing study, and we've now presented data in the study up through week 96. So I won't spend very much time on the study design, just want to remind you that everybody who participated in this study were treated with 3 drugs at the beginning, with 3 different dosing regimens of Islatravir. And after week 20, when patients were achieved virologic suppression, less than 50 copies per mil, they then had the 3rd drug, 3TC, dropped from their regimen, and the control arm of doravirine, 3TC, and tenofovir continued. On this next slide, these are the 96-week results by FDA snapshot approach, which were presented at HIV Glasgow. You can see continued high levels of virologic suppression across all 5 treatment arms, a little lower rate at the highest treatment dose of 2.25 milligrams, but this was really driven primarily by patients who came off study. And what is outlined on this slide are the 7 people in the study who exhibited protocol-defined virologic failure, which was a confirmed viral load of greater than 50. As you can see in the yellow squares here, is in each case, confirmed virologic failure rate level was less than 80 copies per mil. And as you know, a clinically relevant threshold is felt to be 200 copies per mil. So this protocol, as well as the phase 3 program, will be revised to have the virologic failure threshold of 200 copies per mil. This is a table of the ongoing phase 3 program. You can see that there are 4 clinical trials, 1 in highly treatment experienced patients, 2 in switch populations, 1 in a treatment naive population, which gives us the opportunity to look at the safety and efficacy of this 2-drug regimen in a naive patient population, as well as an adolescent trial, which will be beginning very shortly. All right, I'm now going to switch to talk about the 1-weekly program. And the companion drug to Islatravir in this program is MK-8507, which is a novel, potent, non-nucleoside reverse transcriptase inhibitor, which is currently in clinical development. We presented the initial findings of MK-8507 at HIV Glasgow very recently. Preclinical and phase 1 data indicate that it has high antiviral potency with an IC50 of about 50 nanomolar and has activity against common NNRTI resistance associated mutations. Its PK supports once daily oral administration, and to date it's been well tolerated in healthy participants at doses of up to 1,200 milligrams as a single dose, or up to 400 milligrams administered once weekly for 3 weeks. Antiviral efficacy, PK, and safety of single oral doses of MK-507 have been assessed in a phase 1b proof of concept study, which demonstrated that across all doses, the drug reduced HIV RNA levels up to 7 days following a single dose, and it was generally well tolerated at all doses evaluated. On this slide is outlined the PK profile of the drug. And the bottom line here really is that doses of 100 milligrams or above exceeded the PK target of 300 nanomolar at 1 week. This PK or this target threshold was really defined by performing a meta-analysis looking at thresholds across the NNRTI class. And outlined on this study are the viral load declines that were demonstrated in the proof of concept study. As I mentioned, for all levels, we saw at least a one log decline in viral load after day 7. You will note that one participant who received the highest dose of 600 milligrams did develop, the viral isolate did develop an F227C mutation. This is a rare mutation. In fact, Islatravir exhibits hypersusceptibility against this mutation, and we do not feel when MK-507 is co-administered with Islatravir that this particular mutation will be clinically relevant. Outlined in this slide is the study design for the phase 2 study for the weekly regimen of MK-507 and Islatravir. 3 doses of MK-507 will be combined with 20 milligrams of Islatravir and compared to a control arm of Bictegravir, FTC, and PAF. That's a 3-part trial. The 3 MK-507 arms will be then folded into one arm when the dose of MK-507 that will be taken forward in phase 3 trials is determined, and then patients will go forward from there. This study will be beginning shortly. Okay, now moving on to prevention. I want to start by talking about the once monthly Islatravir program. And outlined on this slide is the study design for the phase 2 safety and PK study of monthly Islatravir in uninfected individuals who are at low risk for HIV infection. There are 2 doses that are being studied, 60 milligrams and 120 milligrams. This is an intensive study that will look at tissue PK sampling, characterize the terminal elimination phase or the so-called PK tail, as well as a look at drug-drug interactions with long-acting hormonal contraceptives. This trial is ongoing, and the phase 3 program is in the planning stages. And finally, I wanted to mention a couple of words about the Islatravir implant for pre-exposure prophylaxis. We really have taken advantage of the expertise that we have in terms of Nexplanon or Implanon, which is a contraceptive implant. What you can see here is the Nexplanon implant. The Islatravir implant will be the same size, so the size here, and see a cross section of the implant. And on this slide, you can see the phase 1 study that compared 2 doses of Islatravir, 54 milligrams and 62 milligrams, compared to a placebo implant. These implants were placed for 3 months, and we followed the triphosphate levels of Islatravir across all of these patients. And as you can see, in terms of the mean levels that were achieved, they were above the PK threshold throughout the interval that the implant was in place. The implants were generally well tolerated throughout the 12 weeks and generally mild local, there were generally mild local and tolerable effects. And finally here, on the basis of modeling using the levels that we saw in the implant study, as well as levels from across the treatment programs, the modeling suggests that at the 62 milligrams, we would be able to achieve levels of the triphosphate above the threshold throughout at least 1 year of dosing and probably longer period of time. So I'm just finishing up here by, again, bringing up this slide, which shows you our ongoing development programs for both treatment as well as prevention. We remain interested in studying Islatravir fullest potential. And thank you for